Hello, good afternoon, I think, for most people. Welcome to another dialogue that we've been kind of doing for the last several months as we've watched this pandemic unfold. I think those of us that have been part of this before, the people in the audience that have been watching this know that the format of this is pretty loose. We talk about issues that are hot at the moment, knowing that they're going to be cool tomorrow, and there are going to be new ones that pop up. That's been a trend, I think. We have several people with us today, and I'll start by introducing them. But even before then, what you'll see in your screen is an audience survey. The group of us met the other day to talk about this program, and thought it might be useful to get some feedback from the audience even before we start. It's not a CME program. You won't be pre and post tested to see if you've absorbed this, but we do think it would help us as we have our discussion. So what you see is a series of questions, and you can answer them and do remember to scroll down. If you notice that the bar on the right-hand side of the survey is a scroll bar. And so go ahead and finish that. And while you do that, and this should not be hard for you, it's kind of, do you plan to get the fourth dose, et cetera. Let me just mention the people that are joining us today to engage in this discussion. Two of them are old friends to this format, Peter Chin Hong from UCSF, where I have been associated, Bonnie Maldonado from Stanford University, just down the interstate, and Mike Saag joining us from the University of Alabama, Birmingham. Those that have been part of this before know that Carlos Del Rio, another very familiar person, has been part of this. Carlos was kind of caught in a travel issue today, and so Mike very graciously agreed to step in his place. So welcome to the three panelists, and you'll get a chance to meet them in person in just a second. So we have the results that you have up here. I'm going to just kind of mention them in passing, but then I want us to be able to spend some more time actually talking about them. Do you plan to receive a fourth dose? If so, when do you want to imagine getting it? What about pediatric populations? And what is kind of some of your risk yourselves, your age group and others? And we can go into other questions as we go along. So welcome to the panel, and Mike, especially thanks for stepping in. Mike has the distinction of being not only a great friend and colleague, but also one of the first people, actually the first person I knew that got COVID-19 back in the earliest days of the epidemic, the pandemic. Survived. I don't think has long COVID. At least his brain fog has cleared a little bit. So welcome, Mike, and thanks. Bonnie is a professor at Stanford, is a pediatric ID person, has been very involved in a number of the pediatric protocols. I do want us to dig into that today, Bonnie, because I think we all know it's been quite a mess in terms of the data and kind of the decision-making process. And then Peter Chin Hong is an adult ID person from UCSF. His specialty has really been transplant, infectious disease, and so lots of immunology, and a great person to talk to us not only about vaccines and some of those issues, but also has been involved in the direct treatment of COVID-19 patients and has a real expertise in the treatment of the virus. And I think one of the other directions that I want us to be able to talk about today is where we stand with treatment. What do we see going forward as this whole thing continues to play out? So lots of me talking, lots of background. somebody talked to me about the BA2 variant. Where did this come from, and why? Anyone want to jump in on that?
I think Mike and I can, or we can all talk, but let me just say that right. I do phylogenetic sequencing for a living. Before COVID, I was, I've done a lot of work in eradication of polio. So a lot of my work was in environmental surveillance and transmission of polioviruses. So we already had NIH funding to look at phylogenetic sequencing transmission patterns of polio, and have been trying to look at COVID as well here in our BSL-3 facility. So, all of us have been tracking on NextStrain and GSA websites, the different strains. And I think all of you, I hope, have seen that picture of the Omicron genetic sequence, which is why I think people are so concerned. And it also may give us some hints as to where it came from and where we might be headed. So as you can see on the genetic sequencing, these are all essentially descendants of the parent, the ancestral strain, essentially all of them. So some variability over time, as we would expect, but Omicron just popped up last November, seemingly from a remnant of something from 2020. So that's what's really concerning. And it does appear, we don't know this for sure, we don't have the book and the band played on with patient 0, but not yet. Yeah, that's right. We may have a patient 0 somewhere. I'm not that we want to blame anybody, it was no one's fault, but this virus probably arose within an individual or a series of closely related individuals, because those mutations that we see that are unique to Omicron just don't have any. The most recent common ancestor is, about 2 years ago. So, so this is the concern that many of us had for a while. Given, Peter, you may have some comments about the immunocompromised population and whether that can, give rise to these strains. We don't usually look at, for example, RSV or flu or other strains that are chronically shed in these patients, and perhaps this is what happened.
Because there was some speculation early on that may have been part of the source of this variant, right?
Yeah, well, I think it makes the most sense virologically if you look at the strains. I mean, we don't know yet, and so the question is, will that happen again, or could that happen again? And it's possible. And again, we're kind of at the cutting edge of modeling R-naughts and transmission dynamics at this point. So we have to see what the modeling experts tell us about how these viruses can play out.
Great. So a new variant appears. So we had Delta, we had Omicron, now we have this BA2 variant. It seems to a lay person like me as though we've seen the virus over its last 3 steps become, if anything, more transmissible but less virulent or less aggressive clinically. Is that true? Is that a trend? Would we expect, from what we know about the biology, that's going to continue, so that BA3 will be even less of a concern clinically? Maybe Peter, do you want to let me toss that to you?
Yeah, definitely. I mean, it's a question we get asked all the time. And if you ask a virologist, they say that there's no guarantee that the next variant is going to continue to be more transmissible and less serious, and you can get a mismatch of both. But I think it's also ignoring the soil on which the virus lands. And if the population is getting successive waves of infection and you have vaccination and boosting, you're getting more and more immune as a community. And I think what to me was very compelling was to look at the case of Hong Kong, which hadn't seen the virus a lot from population because of strict border control. And one can say this is the future of China as well. And they are hit so hard. It's like it's March 2020 all over again. And that's really speaking to the fact that we not only think about the virus and virus properties, but we also think about the population. And when you look at the 1918 flu pandemic, there's various theories. Was the population getting more and more immune? Of course, somebody had vaccines then, or was the virus getting less and less virulent? And the answer is probably a little bit of both, or mainly driven by population immunity. And I don't know if Mike or Bonnie, you have anything to add to that.
So just as you do that, and Mike, I'll toss it to you. Kind of let's ask whether maybe Denmark was right and just kind of let this thing go, or was it Sweden? I can't remember, back to the early days.
Oh no,
Yeah.
that was Sweden and Denmark both did it, but in different
Yeah.
ways. But go ahead, Mike.
Okay. Mike, go ahead.
To me, the take-home point of this BA2 is that it is much more virulent even than the original, or transmissible, than even the BA1 or the original Omicron. And I think that's why it's taking over so quick. To me, the key question that we're going to need to watch in the next 3 weeks is what, compared to Europe, where it really has taken off, the enormous spike we had in Omicron was worse here. And did that give us enough local immunity to at least truncate or attenuate the spike that we're likely to see with BA2? That remains to be seen.
Yeah, I absolutely agree with you. And I think that's, in my view, again, who knows, but I think that we either got infected with Omicron or we had vaccine-induced immunity. So right now we're in a sweet spot. I don't know how long that will last, but that's exactly where I think people are feeling cautious. We are doing environmental surveillance around the Bay Area, around the country. We have our own surveillance system here at Stanford that goes up and down the Northern California region, and it's pretty low. We saw a little blips after spring break for the students, but not much out there. And just to come back to what Peter said about Hong Kong, remember, they basically flattened the curve, but they never developed population immunity because nobody got vaccinated, or not nobody, but very few people got vaccinated. So again, I like vaccines. That's what I do for a living. We need to get vaccinated. That's my bottom line. And yeah.
So thanks for opening the door to my next area. So one of the obvious questions, and it was reflected in the questions that we asked the audience to begin with. So here we are. We are watching maybe the beginnings of a surge of BA2, slower here perhaps than we saw in Europe, but we saw what happened with Omicron, where it just exploded. We have vaccines in our toolkit now. Is now the time for everyone to run out and get vaccinated? We just got an email from our leaders at UCSF today saying that they've opened the gates to the next round of boosters. Is now the time to do it? Do we wait? How long after you've been boosted the last time do you get boosted this time? Should we wait until we see if this explodes? Let me go back to Peter and ask him what's your perspective on that?
Yeah, so I'll first start with the science of the booster in terms of what studies we have so far, which is not many, and then we'll put in the US context and context around the world. So the only good data, or only data for the 4-shot comes from Israel, and there are two slightly contradictory studies. One is a smaller study in healthcare workers, about 274. Average age was about 60, and a range that was large. So they got a 4th shot, and the people got 3 shots didn't really seem to look very different in terms of the people who got 4 shots in terms of breakthrough infections, and nobody was hospitalized in either group. So it suggests that, wow, 3 shots really did the job for that group in the surge in Israel for Omicron. Now you look at the bigger study, which was released last Thursday, and that's the one that raised eyebrows. That looked at about over 500,000 Israelis between the ages of 60 and 100, average age 74, so it was a little bit older. And they looked at people who got 4 shots and 3 shots and who died of or with COVID. We're not really sure, but it looks like 0.03% of people who got 4 shots died, and 0.1% of people who got 3 shots died. So again, the take-home point is, wow, 3 shots is amazing. But if you scale up the sort of difference between the absolute deaths in a smaller country, which is Israel, to a bigger country like the United States, you're talking about potentially thousands of lives. So in the middle of a surge. So that's why it's kind of a nuance and a could recommendation rather than a should recommendation. But going through everything, like my mom is in her late 80s, I would want her to get that shot right now. But would I go and get the shot right now? I may or may not, but it depends on what my goalpost is. If my goalpost is prevention of serious disease, hospitalization, and death, I think a young healthy 50-year-old wouldn't have to rush out and get it. But if you're a healthcare worker and you don't want to get a breakthrough infection, you wait for the surge, and then you reconstitute your antibodies so that you don't even get a breakthrough, even though I know 3 shots is going to keep me away from the hospital.
It's interesting because I'm listening to you and looking at the results from our survey that we conducted early on, and our audience skews to kind of over 50, not exclusively, but quite a number of us are in the audience, and the audience skews to yes, they plan to get a 4th dose, but they're about evenly divided by when they plan. Or when they think they're planning to do that. So I don't know, Bonnie, do you want to comment on that? I don't know if you can see these results as well.
Yeah, I saw the results, and that's exactly how I feel.
Who
yes,
knows?
who knows? Yeah. So I think what Peter did is a really great outline of what we know, and I'm frankly waiting with bated breath to hear the FDA VRBPAC discussion next week, because I'm hoping there will be some data that we haven't seen already. I don't know that there will be, but I think the question really has to do with not whether we should get a 4th dose, but when. I'm a little nervous myself because I'm thinking, how long can I wait safely until I get that 4th dose so that I can keep that little boost? The other thing, as we've talked about before on these discussions, is we just had a paper published looking at T-cell responses using an IGRA like assay here at Stanford, and we followed patients that we enrolled in clinical trials who had COVID back in 2020, and we followed them through almost a year, and their T-cell IGRA responses were good for COVID disease infection through 10 months, but after 10 months dropped off. So I do have faith in our immune system, but I don't know how faithful it will be to us in terms of preventing the worst cases. So again, back to what Peter said, if there were really, like over 70, 80, 90 years of age, I think those people should get vaccinated. In pediatrics, for example, we've had families of kids who have really serious underlying conditions, and those children, especially, the ones who are authorized, so those kids 12 and older for sure, if they should definitely get boosted when those are available. And then for the others, I think it's really a risk calculus, and that's unfortunate.
Let me ask about pregnant women, Bonnie, because that's the other half of pediatrics. And we've sensed, I think, lately that maybe pregnant women are at quite a bit of excess risk for COVID-19. Should they be high on the list for the 4th dose, even if they're younger? And what about the effect of vaccination in pregnancy on the health of the newborn?
Yeah, so that's a great question, and actually, I think ACOG and others have really weighed in. In fact, UCSF was one of the first places to publish data on pregnancy, and it's very clear that pregnant women are in a high-risk group. But that said, we have, during Omicron in particular, we had many pregnant women coming in for labor and delivery who were asymptomatic. So I think this also speaks to the idea of trying to figure out how to build some kind of a biomarker so we can see who's at risk. But it is clear that the risk of preterm deliveries in particular and complications is much higher. And we know that the risk of death is higher for pregnant women. But that was pre-Omicron. I don't know whether that's going to be true now, given that so many people have some kind of immunity. But I think one thing to say, though, as a very foundational piece of this, is that the vaccine is safe. So I don't think that's an issue for vaccinating pregnant women. And the other last thing around babies is there was a large meta-analysis that was done recently looking at many studies, over 1,000 children born to COVID infected women, and the infection rate was in the couple dozens. So very few symptomatic kids. So I don't know whether this will translate out into some kind of weird immune tolerance down the line, but certainly the children don't look like they're affected. And NICHD has put in quite a substantial amount of resources to following children over time and pregnant women.
Great. Mike, I started out by saying, commenting on your own infection, and I know there's been quite a bit of discussion, I think maybe even more in the last few weeks, about the results of prior infection, the effects of that on immunity. I've heard some of our colleagues, maybe one of them recently, speculating about maybe going out and getting infected because it might be protective. What's your take on that? And does your prior infection give you a boost up on the rest of us?
Well, I think it
so
does
to speak.
to a degree, yeah. But I think there's a huge gap in knowledge, because a lot of the work that Peter quoted, I'm not sure about the T-cell work that Bonnie just said, but most of it's looking at the pure vaccinated group, occasionally at patients who had infection for sure, but that infection followed by vaccination is kind of a void in data. That said, and I'll speak terribly anecdotally here, but the point is that when I had it, I volunteered for research from day one, and this goes back to March of 2020, and followed out, and I had a robust immune response on every level, such that when I got my vaccine in December of 20, I had this huge amnestic sort of response. It was enormous. So I put off my second shot until August of 21, and I'm dealing with the decision of, do I get the first real booster or not? But I'm confident that my immunity is robust up until maybe this point. I'll probably get the booster now, but we don't really know, is a take-home point. Instinctively, having an infection being followed by a vaccine series is probably the best immunity you can have. That said, nobody should ever get this disease solely for the purpose of immunity, because you just don't know what it's going to do.
Yeah.
Based on what I went through, I wouldn't want to ever go through this again.
And I think it's obvious that we don't yet know everything about long COVID as well. So, or the risk of transmission. So, Peter, what's your take on this discussion?
Yeah, so I agree with Mike completely, and I think that even though you wouldn't want to go ahead and get it intentionally for multiple reasons, and I'm lucky so far I haven't, the people who do get it do have this hybrid immunity that people are talking about. That's the holy grail. When you look at all the objective measures, it seems to perform the best. But and whether or not getting it naturally as well, or in the community plus vaccines counts as a shot itself, probably true. I think most people are considering it like a shot. The problem with, and this is true until Omicron, the problem with Omicron is, for those who are asymptomatic or have mild infection, the question is, what's your, not whether or not you would get a response, which probably you might, but what's the level of antibodies you get? And again, that comes to a question of not solely relying on infection acquired naturally to give you take you across the finish line. And there's good data from the early months showing that the more severe you've had disease, the higher the level of antibodies, like people in the ICU, et cetera, versus people in the community. So putting all of those things together, again, with BA1, BA2, more transmissible, but if asymptomatic, we don't really know what's the number of antibodies and immune response you're getting, the magnitude, but certainly I would count it as a shot.
So let me just remind the audience that there's a Q&A function on Zoom, and we'll try to keep track of the questions that the audience is generating. We want this to be useful for you, and that's one way to do it. And Peter, given your own expertise, a question from somebody who's HIV positive, 35 years old, and got a new liver just before the pandemic started. What should he be thinking, or he or she be thinking? And should he or she go back to work in the clinic?
No, those are great questions. They're very pertinent. So I think for new transplant patients now, we're actually within the first 3 months or so, or even early on, if they hadn't gotten immunized before, we are offering them long-acting monoclonal antibodies, Evusheld, because we're not convinced, say you're coming in unvaccinated, unexposed, you're being hit hard, you're probably not going to develop antibody response for several months, but now we have long-acting monoclonals like Evusheld, although we have to increase the dose with Omicron. We can give it to you temporarily and then give you the vaccine series after. Now, if you're coming in to transplant, you got the transplant a while ago, the question is, have you responded to the vaccine or not? And by the studies, 50% of people in certain high immune suppression groups haven't. So rituximab, transplant, allo-BMTs, et cetera. And those people, anecdotally, even though no national guidance, a lot of people are checking. Well, first of all, you go up to date on your vaccines, but you're also eligible for Evusheld. But the question is, do you go up for the Evusheld or not? And and this is where the art comes in. So a lot of people in practice are checking, spike protein antibodies and seeing what that is. So it can help guide whether or not you would get a long-acting monoclonal antibody. So say somebody like Colin Powell, for example, he has multiple myeloma, plasma cells completely shut down, never making any antibodies. So he can get like a zillion shots and he probably wouldn't respond. In that case, he would really benefit from something like monoclonal antibody. So it all depends on the situation. It's very nuanced, but I think the multiple shots increases the probability of you getting a response as an average transplant person. And we know that in hepatitis B shots in transplant patients and in HIV, sometimes you don't respond with the regular 3. So in practice, we give you one and check your antibodies, another one, so that and there's literature to support this, that some people need 4 or 5 shots.
Yeah, and just so I used to run a congenital hypogammaglobulinemia clinic when I was a fellow, and those poor children, it's a pretty rare immunodeficiency, but those children essentially had no B cells or non-functional, and really we had to, they were sustained on regular antibody. So I think the downside is, not a big one, and I think if you want to monitor with antibodies, I think that's reasonable. I wanted to point out one really quick thing. There were studies now looking at antibody levels, neutralizing as well as non-neutralizing antibody levels and severity of disease. And it's true, you do get big spikes, but they come down fast too. So you have to be really careful with interpreting antibody data because it doesn't really mean protection. It may not.
This is, Bonnie, that's an area I wanted us to wander about in a second. So we've heard some discussion, I wouldn't exactly say controversy, but some discussion about antibodies versus cellular immunity. Which is more important? Which can you measure? Kind of, can you absolutely say, forget about antibodies and rely on cellular immunity? We've heard that perspective. Others, that pretty religiously follow the antibody levels. Thoughts on that and where we should be going?
Well, so, I've studied T and B cell immunity in children, so it's a little different, but it's easier in some ways, because if you have these congenital defects where you block one line or another, it's easier to look at the extremes. So it depends on the virus. So if for measles, for example, T cell immunity is absolutely critical. If you have no T cells, you will die from measles disease, even if you have if you have B cells. For polio, B cells seem to be enough. It's clear right now that B cell immunity is very good at preventing infection for SARS-CoV-2. The question is, what does T cell immunity do? And I don't think we really have a good handle on that yet. I mean, there's lots of studies, and we do know that they play a role, but it's not going to be quite so straightforward as, say, measles or polio on the other hand. And so I think we're just going to have to see. But I do think I don't know what Mike and Peter think, but I think it's a combination. Neutralizing antibodies is critical, and T cells are probably important too, but there's so many different kinds of T cell responses. We don't know which ones to measure. I
Oh.
wouldn't go down that path.
Thanks. So one of the things I love about these is I get to look at the at the at the questions and look for friends, and I see a couple already. So one of my friends who happens to be over 80, Merv Silverman, who is a hero from the HIV epidemic, asks for those people that are over 80 thinking about the next booster, why not wait a little bit longer and see what happens with this possible surge? If it looks like it's really happening, then get a booster versus doing it now. We already talked about that a little bit, but Mike, do you want to comment from Merv?
Sure, hi Merv. I would say that to me, the intensity with which we should look to get that fourth shot is like a grayscale. And as we get over the age of 60 or 70, I think it starts to turn darker gray. So I would encourage, we don't know what it's going to do, and we're really not trying to prevent infection. We're trying to prevent badness. We're trying to prevent people from going in the ICU. So I'd go ahead and get that shot now, Merv, unless if you had encountered Omicron in January, let's say, you could probably count that as a quasi booster and put it off to May or June or something like that. But I don't want to see you or anybody else get real sick with this. And that's what I think we're talking about here, moving on into the future.
So a question that came up in my email today, and I see it, two people on the Q&A, including Bill Owen, who is another hero of the HIV epidemic. People are saying, okay, now we have, right now we already have Pfizer and Moderna. People have already gotten perhaps J&J vaccine. What's the current thinking about kind of mixing and matching versus hanging in there? Now that I've gotten, I'll just raise my hand, 3 doses of the Moderna, is it better to stick with that? Do I stay, true to my school, or do I switch off and try to broaden my my immunity a little bit? Any of you can comment on that, I'm sure.
Well, there was a study out of NIH back in October-ish that showed that there was some value to switching, and just that plus instinctively giving the immune system another look at a little bit of a different variant of sorts, this time a vaccine variant, if you will, I think makes sense. So if you've gotten 3 doses of Pfizer, you're going to get a 4th, get the Moderna. It's important to remember that that booster of Moderna ought to be the 50 microgram, not the full, what we used to use in the original series of 100 micrograms. So make sure you're getting that. And vice versa. If you've gotten Moderna along, switch to Pfizer. I was curious what Peter and Yvonne said.
Yeah, absolutely. That NIH study, I would love to see an update of that was presented at one of the VRBPAC meetings in October, and it was about 50. No, it was about 50 people, right, Peter? I think it wasn't a lot of people, but it definitely showed that mixing and matching is great, and it almost didn't matter. I think Moderna came out doing better, but they were at this point, I think, whatever you do, getting more repertoire, antigenic exposure repertoire is probably a good idea.
So I'm hearing maybe it is good to think about broadening as you enter your next booster shot. Peter, any thoughts?
Yeah, I agree with everything that people said. I'd only add that the current preferred vaccines right now are the mRNA vaccines and not J&J, not because it's not effective, but rather because, just the smaller risk of clots in some people. That's why they prefer the mRNA. But there are also, interestingly, going to be 2 other vaccines in the pipeline if people want to really mix and match, like a chocolate variety box. The Novavax, which I really like just because it's similar to the traditional vaccines, like a subprotein vaccine, and the GSK Sanofi vaccine, which actually looks to perform really well. So a lot of things still happening. And the reason why those vaccines are important is because some people really, there are really few people who had like terrible not serious side effects, but like the ones that they couldn't take anymore, and some people even got rash. They wanted to, sometimes some of them wanted to just wait for another vaccine type. So that's why I mentioned that.
So another question from the group has to do with the efforts that are underway now to create specific Omicron vaccines. Is that something that people should watch for? Is that something that we should be trying to get, or is the current approach adequate? Anybody?
Yeah, so those vaccines are in trials now. So there is a Delta Omicron variant that's being looked at least two. There have been a number of oral vaccines, nasal vaccines. The orals have not done so well, mostly, not sure why. We haven't seen the data, but they didn't really do well. I think one was in Israel, and I forget, the other one was in India, I think. But yeah, so I think we should watch them, but I think we should still make sure people just get the vaccine that they have right now. And I do think, somebody mentioned, what's the next stage, or should we be calling these boosters? I think semantics are important for the public, for sure. And I do think we're headed into a period where we're not going to call these boosters anymore. We may wind up with, if you think about the 1918 flu, for example, the flu that we see now, the H1N1 that we see now, is a direct descendant of that flu. So this virus may be around for a long time, and hopefully it'll just turn into a cold virus that doesn't kill 1% of the population.
Yeah,
but it's not gonna, it won't happen. I don't think it's going to happen in the next year.
Maybe one day we'll have a sorority or fraternity vaccine that's called Omicron Delta Gamma, or something like that.
I think we could already do it, Mike, don't you think? One of the things that I heard earlier is from one of you is some of the language that we hear, the communications, and I think we've all, in watching this whole pandemic, been struck by sometimes the bizarre communications that happen. And Bonnie, maybe I'll toss this to you to start with, but guidance from the CDC now seems to be less should and more could, or you might versus you must. Talk a little bit about the state of the art of communications in this whole field, because I think people maybe are understandably getting confused.
Yeah, I think, so this is the great audience for that, because I think that the public still trusts scientists, and to a certain extent, and healthcare providers, and the way we communicate to the public is critical. And I think we need to be very careful about what we say. I do think that CDC and FDA and other agencies have, it's hard to, I think one of the things we have to learn is how to build a scientific platform for communicating to the public. We haven't done a very good job of that. I think Operation Warp Speed, to a certain extent, did a very good job of their message, but they had a very focused message. They had one thing to do, essentially. And they used the DoD piece of that to build out, okay, give me your list of things you need to deliver, and I'll deliver them. I literally had a giant pallet drop shipped in the parking lot of our football field in March of 2020. And I had no idea what it was for. I figured it out eventually. But the point is, they're great at delivering stuff, but we need more nuance about who delivers what message. And that's, I think, really critical for our administration, our federal agencies, to be able to point to, you're the expert in this area and you're the expert here, and how do we do that? And to be fair, we've never had, we haven't in our lifetime had a pandemic like this. But we didn't do such a great job in 2009 either with that pandemic flu either. So I think we need to learn a lesson.
Other thoughts, Mike or Peter?
Yeah, I mean, we got to give everybody a break here. I mean, this thing's been with us 2 years. That's it, 2 years. And we're learning as we go. And thank goodness we've got these miracles around us, treatments, vaccines. Holy smokes, going back to the early days of HIV, we didn't even know it was caused by a virus 2 years into the epidemic. So processing that information, having a mind of a scientist who doesn't like talking in absolutes, at least until there are absolute data. And we have to, the public doesn't get into the nuances of well, there's a probability or whatever. So what I've resorted to is likening all this to the weather and saying that these waves are going to be like storms hitting us periodically. And now we're at a place where we can put our umbrellas down and be okay. When the next storm comes, we really need to get into our safe place and use our masks again and doing all those things, getting prepared now with vaccines and being prepared with medicines, rapid tests, getting treatment quickly if we do convert to positive and manage the epidemic rather than letting it manage us.
So a question that I see on the Q&A that I love is sort of, let's back up and ask whether vaccines actually prevent infection. To what degree, how successful are these? Do we have all of that data in hand versus obviously preventing a serious disease? And the question says, for example, sports teams where people have been vaccinated and yet, a whole bunch of them get infected at the same time. Anyone want to comment on that data?
I don't think we have really great data to show us what the reduction in infection is. I do think that we do have some evidence of decreased infectivity, but this is now, we're not at the point where we were in January through March of 2020, where everyone was susceptible. Now we have, it's like flu, right? So why don't we know how serologic data translates into protection for flu? Because there's so much variability in what we're protected against, depending on when you were born, what strains you were exposed to. So I think it's not going to be easy to determine that with certainty, but I would say that there's good data looking at viral load. I'm sorry, Mike, you're the viral load expert here, but I think we've seen enough data that we do think that the vaccines do reduce infectivity for sure, at least in the laboratory and probably in some human studies. I don't know that we can calculate the real relative risk reduction of infection with the vaccine, but it clearly, as you pointed out, Paul, we don't want to stop every sniffle or every cough. We want to keep people out of the hospital, and they certainly work in that respect. So whether it translates out into less infectivity, less transmission, or just less symptomatic disease, I think we're probably getting a degree of all of those. We just can't prove it all yet.
Great. Other thoughts, Peter? Mike?
Yeah, I agree with Bonnie. I think one point that Bonnie had brought up before in our pre-discussion, which I loved, was that as the population becomes more immune, you get a mixture of people who are called unvaccinated, but they've actually been exposed. So when you compare the control to the intervention, the control is actually looking immunologically more similar to the intervention, minus the vaccine, the more you progress in the pandemic. So the vaccine, and I think, Bonnie, that it might be interesting for you to comment on the kid vaccines and how the control group may or may not be different from the exposed group anymore. The vaccines will look more and more similar in infection to the control group versus serious disease hospitalization. And that, I guess, no one will dispute that the vaccines have been really powerful in that regard.
Right. So in the Q&A, question is kind of going back to Mike, sort of again back to the communication. The question is, White House announced booster policy before the FDA approved it, and then we find out next week from the committees what they think. Again, going to this idea of communication, and are there and I know you answered this already, you addressed it already, but where should we be turning? And if we try to think of what have we learned and how might we do a better job of communicating this, thoughts about that?
Well, yeah, I think, again, I have sympathy for what the feds are going through with this. It's tough. It's very hard. I think what they tried to do with the approval of the fourth dose was basically saying, what's the harm versus what's the potential benefit? And we feel like there's an emerging explosion of Omicron BA2 on our doorstep, we don't want to get so bogged down in process that we miss our window. So I think that's what pushed it along. And they're probably right that it's probably safe and that the effectiveness could well be there, especially for the older folks like me and some of us on the call today. And that it does make some sense. But on the other hand, process matters, especially when you have controversial things. So I think maybe a lesson learned here was, we should have just had the group meet and not created the impression like we're railroading this. But at the end of the day, they'll meet. I think they'll have the same conclusion, but it takes a couple of hits in terms of credibility.
And it was nice to see your dog behind you there, Mike. It's always a great thing. I couldn't tell if it was a cat or a dog at first, but we've gotten to watch each other's animals over the time of this. Bonnie, just something that's totally non-controversial. Maybe you want to address a little bit is, what do we know about pediatric vaccination?
Oh yeah, not controversial at all. That's why most of the kids in the U.S. aren't vaccinated, right?
What's the single quick bottom line, right?
The bottom line is it is better for children to be vaccinated than to not be vaccinated. And honestly, that is the message that we're hearing from the Kaiser Family Foundation, from others that are doing surveys. Families, it's not that they're afraid of the vaccine anymore. At first they were afraid. Now, I think people just think, well, the kids are just going to get a cold. Why do I need to get them vaccinated? That is absolutely not the way we run pediatric immunization schedules. We in this country now prevent 35,000 deaths a year from vaccine preventable diseases using the vaccines we have now. Now 35,000 deaths pales in comparison to what we're seeing with COVID. But if you can prevent a death in a child, why wouldn't you do it? So I think that's the message. It's a safe these are safe vaccines, 11 billion plus doses in the world, 20 million doses in kids in this country now of these mRNA vaccines. So that's the simple message. And again, speaking about communication, I don't know how else we can get that message out. It's very difficult. And then of course, there's a lot of fear about, but so you have both ends of the spectrum, because we also get people who absolutely say, I'm going to give vaccines to kids under 5, even if they're not approved yet, because we want those vaccines. So we can't do that either if they're not approved, but we hopefully will get there soon. So yeah, it's a spectrum, like you said, but obviously safe, obviously effective. It's really just a matter of risk perception, which is what we've been saying at, I think, every one of these town halls.
Right. And I want to get to treatment in a second, but Bonnie, there are a couple of things that have come up in the Q&A that trigger that. Myocarditis, which I think know is more of a risk in young people. Another person mentioned possible Guillain-Barré as a vaccine. Where are we in terms of safety of vaccines for younger people?
Yeah, so the data on myocarditis has showed a couple things. The first, briefly, and I'm not a cardiologist, obviously, but first of all, our cardiology colleagues, especially pediatric cardiologists, say that first of all, basic viral or other non-infectious myocarditis is very severe. It can be very severe. COVID disease induced myocarditis can be very severe. Vaccine-induced myocarditis is on the order of about 6 dozen cases per million boys between 16 and 29 who are boys and men who are vaccinated. So the risk is about 1 in 14,000, and it's very mild. It can pop up within a week after vaccination. Many of these kids have chest pain or shortness of breath, but they resolve very rapidly, and the long-term follow-up has been great. In the adult data from MMWR about a month ago, there have been 36 cases reported among about a third of a million cases that are
so really rare.
So pretty rare. Yeah. That's the major risk. I think there are other things, but they're not. GBS has not had a big signal, and Nikki Klein at Northern California Kaiser has shown that as well.
Great, Peter. So where we might be going might be like Tamiflu for influenza. Do you want to talk about treatment, especially, I guess, especially Paxlovid, how that's fitting into our thinking as we maybe enter the next phase of this pandemic, and what should people be thinking in terms of both their patients and maybe even themselves?
Yeah, so great question. I think we're moving, like much of drug development, from the hospital into the community, try to get people earlier. And I think right now, Paxlovid is the golden child of COVID therapeutics, because it's generally safe with, you have to watch for drug interactions, but extremely effective if you are at the right risk category. So the bigger the benefit, obviously, the more you're susceptible. So in the study of unvaccinated people who have medical comorbidities, 89% effectiveness in preventing hospitalization, if taken within 3 days, 88% within 5 days. So really great. The problem is right now, initially not enough, but now more, because people aren't, getting COVID right now in a lull, but people just don't know about it. They don't know how to access it. Not only patients, but providers as well. They haven't used it. They don't feel comfortable. People haven't really talked about it. They gave this website yesterday from the Biden administration, One Stop Shopping on the COVID website. But again, you kind of have to be computer literate to figure it out. Doesn't work as well on your phone versus the website on their computer. So it's very clunky. So to get the test and treat, which was again modeled after HIV, for Paxlovid being the model, you have to do a lot more systems work, work with pharmacies. Somebody still has to prescribe it. In the absence of a national healthcare system and information system, you want to hope that your drugs are going to be somewhere that somebody can run the drug interactions with. And all of this has to be done within 3 days after you get the diagnosis, prescription, get the treatment, take it. But if you do all that choreography, you can have a big bang for the buck. So that's the treatment. For the prevention, I think a lot of people are studying now, well, not a lot, but they're studying now using it for post-exposure prophylaxis and high-risk exposures like households, et cetera. I predict that will be positive. And you're right, Paul, it will eventually be like a Tamiflu situation. The molnupiravir, only 30%, that's a Merck drug, but it's still 30% is better than nothing. So if you still had a choice, you'd probably still want to have access to that if there's short supply of the other. And alternatives are remdesivir for 3 days, but you need an IV. And monoclonal antibodies are dropping off in efficacy, particularly with BA2. So the only drug that was previously left was sotrovimab, which was made by Vir just in the Bay Area. But that's, got put the kibosh on with BA2. And then the only drug now for monoclonal antibodies with treatment is, I can't even pronounce it properly.
Yeah, whatever.
Made by Lilly, because Lilly had the Bam, we used to call it Bamlanivimab, wasn't as effective even with Omicron. So then they made an improved product. So that's the one that we have. But, Paxlovid is as good as that, easier to take, easier to scale up, but test and treat sounds great, but the devil is always in the details.
And I think you were telling us the other day that there was a case recently of somebody who clearly had just been diagnosed, talked to her doctor, and the doctor said, no, I wouldn't recommend it.
And I've heard those stories over and over and over again. I've had so many emails, calls from patients who said that their providers didn't know or didn't know how to get it or didn't think they would benefit from it necessarily because it seems like you just have a cold. But the point is, in the right person, that cold, as we know, could turn into something else, and you just don't know.
So, I just wanted to make a comment about this. You mentioned Tamiflu a few times, and I get nervous about that because we do a lot of guidance for the American Academy of Pediatrics, and I have a lot of physicians who don't think we should be giving Tamiflu for flu. and oseltamivir for flu.
Even though the vaccine this year proves to be not effective at all, right?
And but they keep saying, well, where's the RCTs, and we need all of this data, and the benefit is first of all, the risk is incredible. There's no, it's a very benign drug, as well. Paxlovid has some drug interactions, but I'm talking about oseltamivir for now. But even getting people to want to do something like that for flu has been very difficult. I can't imagine, I don't want us to lapse into this sense of it's normal to be COVID positive and not do anything. We're not quite there yet. I don't think. We may be, but we don't know that yet. And I worry, and I think want to reinforce what Peter said about the devils being in the details.
Mike, what are you seeing with treatment in Birmingham? Or thoughts on this?
Yeah, it's picked up pretty well. I mean, remarkably, I've been very happy with, for the most part, with the uptake of antivirals. Maybe it's because we've been in people's face a lot on TV and whatnot, but I think it's critical to go back to the basics here. Remember that the first part of this infection is a viremic phase, and it peaks out about 3 to 4 days. If we can get treatment to people on day 1 or 2, after onset of symptoms, we can nip this in the bud. Waiting till day 6, 7, or 8 is almost too late. And for me, just kind of relating this again personally, I wasn't all that day 1. I didn't waited to get.
Seeing my connection here.
Yeah, I think we may have lost him, but
Am I still on?
No, you're on. I think it was Mike. I think what he was trying to say is that, oh, sorry, Mike, can you talk now? We lost you there.
Maybe cut your video.
It's a viral disease. With a cold, go and give it now and don't wait.
Yep, agree.
So I'm wondering, I saw something in the chat. Remember we asked people at the start of this what they were thinking about doing. If I don't know if our technology or internet connections are starting to fail us, but I wonder if it's possible to toss up those questions again. We don't care if you change in your age since the start of the program. But I think in terms of your inclination to get the next dose, have we changed any minds here, or are we still about as divided as we were to begin with? So here we are again. So here is the audience survey. Do you plan to get a 4th dose? When? Why don't we? And then pediatrics. I think that would be an important one to ask again. So if people can answer that really quickly. And if I can see the results, I'll try to remember what we had at the start of the program. We only have a few minutes left. I would say, just in anticipation of closing the program, that it's been a great discussion as always, and certainly a lot of questions still remain. It's been great seeing all the participation from the audience. Sorry if I didn't mention all of my friends that I see on the list, but we appreciate you all being here. So here it is again. So this is the new response. So it looks to me, I'm not going to try to quote numbers, but it looks to me like we've definitely seen a swing in terms of people that plan to get the 4th dose. I'll raise my hand for that as well. And in terms of when people are thinking about getting it, I'm eyeballing that to say, yeah, still about as divided as it was. And I think some of the discussion that we heard was, and this was kind of going back to Merv Silverman's question, maybe as we watch the next wave come, maybe we want to wait a little bit versus jumping on it so that we're ready when it does come, if it does come. And then Bonnie, for the pediatrics, I don't remember the data from the start, but
yeah, unfortunately, the way the question was, you could only answer one.
Okay,
and it was but I think it was helpful that people did pick 5 to 12-year-olds as the most important group right now, given that that's the group with the lowest rate of vaccination. 70% of 12 and older are vaccinated, and only about 25% of 5 to 12-year-olds are. So that is the group that needs to be vaccinated now the
Right.
most. Yeah. So
Well,
sorry about that.
guys, thanks so much. We've covered, I think, quite a bit of ground in our dialogue today, and mostly thank the people for being on the panel, and for the people in the audience for giving us your questions and feedback. It's been great. Sorry if I didn't get to everything, but also thanks to the staff at IAS-USA, who, as usual, have done a spectacular job of putting this all together. And stay tuned for the upcoming programs that the organization has. So thanks again.
Thank you all. I think we have everybody leaving now, so I can just say a quick thank you to the three of you. What a great, we saw Peter left. What a great dialogue once again. Mike, thanks for pitching in.
Yep. Okay, bye,
Sorry
everybody.
about that. My
Art,
internet
from
service
moderating as
provider
always,
let me down. Okay.
Okay, have a good weekend.
Thank you
Have
for
a good
including.
weekend, everybody. Take care.
Thank you.
Bye.
Bye-bye.
Bye.